Mode.
Hello, everyone, and thank you for joining us for another webinar sponsored by SEPA. Today we have Peter O'Neill, who will be presenting a webinar on exercise programming for older adults, a case study approach. Peter O'Neill is a clinical exercise physiologist and a clinical associate professor of exercise science in the Department of Physical Therapy and Human Movement Sciences at Sacred Heart University in Fairfield, Connecticut. He is also a fellow of the American College of Sports Medicine. He is an associate editor of ACSM's Health and Fitness Journal and author of Do It Right Exercise Technique column and the Special Population column editor for NSCA Strength and Conditioning Journal. Finally, he is a former member at large of the Clinical Exercise Physiology Association. And he's also worked for 17 years at Albin Rehabilitation Center in Bridgeport Hospital. I'd like to welcome Peter.
Thank you very much, Tim, and thank you to everyone who's attending the webinar today. And I'd like to thank Ms. Tracy Rush from the American College of Sports Medicine and the Clinical Exercise Physiology Association for making this possible. So, as Dr. Warner mentioned, we're going to spend a little time just talking about some exercise testing and programming principles for older adults, and we're going to use a case study approach. So what I'm hoping that you will be able to do at the end of this is to develop some strategies to help you manage risk factors in your older individuals, and to identify them quickly and to use some very accessible electronic tools to help you do that, and discover some new resources that will help you to design safe and effective programs for older adults with comorbid conditions. So, without any further ado, let's jump into our first case. Let's jump into the case, and your case is Monica. Monica is a 70-year-old married grandmother and an assistant manager of a large office. She's an ex-dancer and a seasonal tennis player, and she takes her 8-month-old black Labrador Retriever, Trevor, for daily walks along her beach, but she's finding it increasingly difficult to control him when he gets excited. They walk half a mile in 10 minutes, and she reports having general muscle soreness and some back pain during their walks. She's quoted as saying, "I just don't feel as strong and energetic as I used to, and I wish it was easier and less stressful to control Trevor. I would like to start playing doubles tennis again this spring." Now, last week she was washing and waxing the floor on her hands and knees, and she couldn't get back up when she was finished. She didn't experience any pain, but couldn't get up from a kneeling position. She takes the bus to work and finds that lately she cannot get off at her stop in time unless she sits in the front of the bus. So Monica recently had a physical exam a month ago, and these are the results of her physical examination. And you can see her height. She's 5'4" and weighs 160 pounds. She has a waist circumference of 36 inches and a hip circumference of 37 inches. She had bone mineral density testing, and it was determined with DEXA scanning that her lumbar spine and her hips at the Ward's triangle were determined to be 1.8 and 1.9 standard deviations lower, respectively, than that of a young 30-year-old woman without bone disease. Her skeletal muscle mass, which is a measurement of skeletal muscle quality, was considered to be 2 standard deviations less than a young, healthy woman without sarcopenia or any muscle deteriorating diseases. Her fasting glucose is 110. Her resting heart rate is 70. Her resting blood pressure is 124/70. Her cholesterol, total cholesterol, is 130 milligrams per deciliter. And her high-density lipoprotein cholesterol is 30 milligrams per deciliter, and her triglycerides are 150 milligrams per deciliter. Monica denies any other symptoms or discomfort. She wants to continue walking daily, and she wants to start playing tennis again and have the physical reserve necessary to do so. She wants you to develop an exercise program she can do a few times a week to improve her health, physical fitness, and her health-related quality of life. Important to note, she's taking metformin, also known as glucophage, Zestrel, lisinopril, Tenormin, atenolol, and Crestor, rosuvastatin. In addition, she's having a monthly injection of ivandronate, also known as Boniva. And below here, I've put a couple of resources in that I think would be good for your toolbox. And I've added the URLs for these, the links to these, and these will appear in the handout that Dr. Warner makes available to you at the end of the webinar. I believe it'll be in PDF format. But drugs.com, health topics and drugs and supplements from the medlineplus.gov website, which is a huge search engine. In addition, it would be good to have the 10-year cardiovascular disease risk calculator, and then something called My Life Checked, Life's Simple 7 screening tool from the American Heart Association. These are some newer tools that make our job so much easier. Okay, Monica had a treadmill test in addition, just 2 weeks ago, and she completed 12 minutes during a modified Naughton protocol. She did not do the Bruce protocol. She used what's called a modified Naughton protocol, and you see that down below on the right-hand side of the screen. During the test, she was able to get to a peak or near maximal heart rate of 148 beats per minute. Her blood pressure was 170/70 millimeters of mercury, and her Borg scale rating of perceived exertion was 18 out of 20. The test ended, and she experienced just general fatigue. Her physician stated that it was an unremarkable test. She did experience low back pain, and when she got off the treadmill, she had to place both of her hands in the small of her back, in the lordotic curve, in the lumbar spine, and lean gently into that. And in approximately a minute after that, the pain resolved. It went from below the buttocks up, and it centralized, and then it disappeared. The EKG was normal with exercise, and again, her physician's impressions were that the test was unremarkable. What I'd like you to sort of draw a note to is to look carefully at the 6-minute mark on this test. Actually, the 12-minute mark here at this test. She stayed 6. So I'd like you to just look at that for a moment and make that relevant, okay? Her physical capacity at that point. It would be approximately 6 minutes. Okay, so I have a couple of questions for you about Monica. So after listening to some of her profile, what condition or conditions do you believe Monica has? Would it be osteoporosis? Would it be sarcopenia? Would it be osteopenia? Would it be obesity? Would it be renal disease, Alzheimer's, or other? We have 2 tools here to help us make this decision. One is from the National Stroke Association on the right hand of the screen, and this is called the Stroke Risk Scorecard. It's a really nice, comprehensive, quick and easy tool. Very easy to use this. And then just a reminder on the left-hand side of the current staging of the metabolic syndrome factors. Another question for you is, what type or types of medications is she taking, and why might she be taking those? Okay. Another question for us to consider is, what is Monica's stroke risk? Is it low? Is it moderate? Or is it high? Down below is a link to help to determine this, and for you to access this pretty easily to get this tool. Okay, so I'm going to have you think for a moment before we go a little bit further. Okay. So here are some impressions. Monica also has dyslipidemia based on her low HDL and her high LDL. She has abdominal obesity based on her waist size, but also on her waist to hip ratio. She has hypertension and impaired fasting glucose. She's taking metformin, glucophage, and she's taking Zestrol, an ACE inhibitor, for her blood pressure, and atenolol, which is a beta blocker for blood pressure. She's taking Crestor, rosuvastatin, and that's a statin medication for her dyslipidemia. And she's taking an ivandronate monthly injection for her decreasing bone mass. In this case, she has osteopenia, not osteoporosis. Her 10-year cardiovascular disease risk using the 10-year tool is 12.3%, which places her in a category where moderate to high dose statin medications are currently recommended in most patients. In addition, her reduced bone mineral density T-scores in her lumbar spine and femoral neck. Two very common fracture sites place her at a higher fracture risk. Due to her elevated fat mass and presumed reduced lean skeletal muscle mass and skeletal muscle quality, and due to the fact that she has reduced gait speed and grip strength, she is considered to have sarcopenic obesity and what is called dynapenia, or poor skeletal muscle quality and function. She is also at risk of a stroke, at higher risk. So now let's look at her physical fitness test scores. So your staff comes together and puts together a testing battery. And a large percentage of the assessments are coming from the senior fitness test from Drs. Rickley and Jones. And this was a test that was validated initially in over 7,000 elderly individuals, and the cohort age range was between 60 and 94 years. So there's a robust set of data on this particular test. And this test basically assesses health-related and functionally related fitness in older people. So here's a profile. She did the 6-minute walk test, and she did it. She was able to complete 457 meters. And she also did a second test of cardiorespiratory fitness called the 2-minute step test. And that's this little assessment right here. And the kneecap has to break a line that is midway between the top of the patella and the iliac crest. And both legs have to do that. It's important to look beyond the test and not just look at the quantitative scores in the norm charts and tables, which we're going to do in a minute to rank the person, but you also want to use your clinical vision as to what types of movement strategies your client or your patient are engaging when they do these tests, because a lot of other things may jump out that are not told by the story of the norms and the scores and the numbers of repetitions and such. So things like balance or balance deficit or stability deficit, proprioceptive deficit, weakness, unilateral or bilateral, these things can all jump out, dizziness, and you can also surmise a number of strategies that an older person uses to right their balance, whether they have a good, strong ankle strategy to correct themselves or not, or whether they use their trunk and have poor control type of thing. So these are important to look at as well. She did fairly well on the chair sit and reach test and the upper body back scratch test with a ruler. That's kind of an adaptation of the athlete back scratch test. She also did the 30-second arm curl test and the 30-second chair stand to test upper and lower body strength, respectively. And she also performed the 8-foot up and go test, which is an indicator of dynamic agility. There is a gait speed element in there. There is a little bit of a power element in there, but there's definitely a dynamic balance and anticipatory cue factor that comes out during this particular test. And that's what this particular, so what you're seeing here is the 30-second chair stand test. Okay, so that's the 30-second chair stand test right there. And then over here, I'm going to show you just very briefly the 8-foot up and go test right here. And what you're seeing is, if we can get the video to move here just a little bit, on the far right hand side you're seeing gait speed. You're seeing self-selected gait speed, and the subject's toe, as it moves over the starting line, the stopwatch begins, and it will stop when a toe crosses the other side. And then the walking velocity is determined by dividing how far the person walked by its time. And in this case, we're doing it in meters because metric is the use of the universal label for that. We're not able, for some reason, to make this particular video play. So my apologies. Here it goes. Now it's coming. So what you're going to see here is that the patient is getting up, and this is in slow motion, is going to get up and is going to walk, and they are going to traverse this cone. And we're looking to see how fast, I've sped that up a little bit. Let's try that again. We're looking to see how fast they can complete the whole task, and that's compared to normative data. But the more important thing, when we look beyond the test qualitatively, is to see what kinds of strategies come out when she gets closer to that cone. Does she stagger? Does she festinate? Or does she hesitate? Does she take a very wide turn? Does it require multiple steps, short toddling steps to get around, or is she able to just kind of turn and pivot without losing her balance? And when she returns to the chair, is she able to turn quickly and tightly? And does she have good eccentric control when she's lowering her body back into the chair? Or does she fall, or does she lean to one side or use her arms? And there are a series of patterns in movement that you can also look at when she gets out of the chair. Is she moving symmetrically, forcefully? Does she need to use multiple attempts and rocks to get herself up, or can she forcibly extend her hips or knees and her ankles to do that? And are each of her steps propulsive, or does she sort of retropulsive, go back? So all of these things, the reason I'm mentioning them are they may give you some cues as to what Monica might be like during her exercise program, and at what level of complexity some of the exercises might need to be, or whether they need to be titrated or regressed down a little bit. And then again, we have grip strength. And it's been determined that if you really don't have a lot of time to do any assessments with older people, that if you can at least do a grip strength test and a gait speed test, you can then determine their likelihood of a fall risk, their overall health and vitality, their life expectancy. You can also start to begin to, if you also know body composition, you can see if they have sarcopenia and or sarcopenic obesity. So we do have kind of a robust amount of information here when we look at Monica. And her gait speed, if we do a determination right now, her self-selected walking speed is approximately 0.93 meters per second. So we're going to tuck all these scores away for just a second, and we will be revisiting the score and these tests so that we can put this into relevance. So the next questions that we would probably want to ask regarding Monica are, what items from the senior fitness test has she entered what they would call the risk zone? So in a moment, we're going to compare her results to the norms on the next slide. Which fitness or functional parameters warrant improvements? What is Monica's self-selected walking speed in meters per second? We kind of determined that to be 0.93 meters per second already. And does Monica have the required velocity to cross a busy intersection in time, or to get off the bus quickly while it's stopping if she were at the back of the bus? And if time permits, what other assessments could be appropriate for Monica? So these are some norms that come from Dr. Rickley and Dr. Jones's manual for the senior fitness test, but this came from an article that appeared in 2002 from the Journal of Active Aging. And these are your norms for each of the scores, each of Monica's scores. And so if you'll recall here, in the 30-second chair stand, Monica basically she didn't do tremendously well on this. She did 10 repetitions. And if you go over to the table here, you can see she's a little bit below that medium or the mean scores, but she's not quite in the risk zone. The risk zone would be, well, actually, she's just about on the border of the risk zone, so I'm going to say she is. So less than 8 unassisted. She did 8. But we're going to say it's too close for comfort. So she's at what would be called the risk zone. Now with her arm curl, we can see here that she did 7 repetitions. And again, she's below average, and she is definitely in the risk zone there for arm strength. Now with the 2-minute step test, she performed 60 steps in the 2 minutes in the allotted time. And again, you can see here, with the 2-minute step, she's below average, and in this case, she's entered the risk zone for that as well, and that's an assessment or an indicator of cardiorespiratory endurance for her. Likewise, in the 8-foot up and go, she did this in 8 seconds, and again, for her 8-foot up and go, that's definitely below the average scores or the mean scores for someone of her age. Again, she is, if she were to do 9 seconds or more, she'd be in the risk zone. So she's getting some very borderline scores there. So she's on the cusp of being at risk there with her dynamic agility as well. Her hand grip strength combined, when we combine the dominant and non-dominant hands and give 3 trials in each, these scores are in kilograms, comes out to be poor. Okay. She also did a gait velocity test, self-selected gait speed. We determined that to be 0.93. When you look at her waist and her hip measures, you can see that she is at risk there as well. She's above the 0.85 factor that would then put her at risk, and we put her in the obese category. And her determined percent body fat with bioelectrical impedance is 33%. And there are some flaws with that technique if external factors are not controlled for. Okay, so let's move on here. So a couple of other things that are kind of important to know with Monica are that the European Working Group for the definition of sarcopenic obesity, they look very carefully at a couple of factors, as I just mentioned. They look at grip strength and basically self-selected walking speed. And this algorithm that you see here with older adults requires that you just take a simple hand grip strength test, and she did poorly on that. And her gait speed was just above the 0.8 meters per second, that cut point. So she's hovering very closely to being at a very high risk of fall and fracture. So you're seeing, just again, a couple of quick little examples of those 2 assessments, of how to do those assessments. I'm sure many of you use these routinely. Okay, so there's the gait velocity test. And with the hand grip dynamometer, it's good to just make sure that the dial is facing away from the subject. They're giving it a maximal effort. And there are a couple of different protocols. There are some protocols where the arm is held at 90 degrees of shoulder flexion with the elbow extended. But for this particular protocol, typically with older adults, it's often done as you see on the screen. And in frailer or weaker individuals with less upper body strength, there are cases where a subject will sit with their arm resting on the table to do this. And we're just looking at the cross-sectional area of a femur of a couple of different people. And what you see in the middle slide there is very poor muscle quality. That's an example of dynapenia, where the skeletal muscles, the quadricep muscles, are so atrophied, and there's such a decrement in muscle mass and cross-sectional area. There's large infiltrations of both intramuscular and subcutaneous fat there, and that's what you're surmising when you do some of these tests. And if you can also add in a good assessment like a quick anthropometric assessment, body composition assessment, as you will. What I'd like to draw to your attention down below is this gait speed life expectancy curve. And what this curve is showing you is, through the age cohorts of 60 to about 95, is that survival rates are significantly higher for people that walk faster. The faster you walk with self-selected gait speed, as you see up in the top left corner, the longer your life expectancy is. And the green areas, when you go from left of the screen to the right, represent those cut point gait speed scores that extend one's life expectancy and, in theory, health-related quality of life in each of the 10-year cohorts. And what you see in the yellow and red is how there are significant decrements in life expectancy and quality of life at these speeds. Let's keep in mind right now that Monica's self-selected walking velocity is 0.93. So at her age, at 0.93, she's in the middle of the yellow zone. If we go to the right and we look at this algorithm, this is a graph that takes specific functions, activities of daily living, and instrumental activities of daily living, and also looks at independence, and it matches those tasks with the requisite gait velocities in order to complete them. Keep in mind again that Carolyn's self-selected gait speed is 0.93. And you'll notice in the middle of the screen the 0.8 meter per second velocity, which puts somebody, that's the cusp of whether somebody is at or is not at risk of functional decline. Notice that to walk across the street, a busy intersection, independently, it requires a gait velocity, a self-selected gait velocity of at least 1.2 meters per second. what you see below here are different ways to render a walking speed test. And this is just showing you when you're using different distances, whether it's in metric or in feet, what the corresponding speeds and velocities would be and where they fit on this particular tool down below. We also would want to be concerned with what's called skeletal muscle index, which is a surrogate measure of appendicular skeletal muscle mass. And typically, a cut point of 6.42 kilogram meters per squared or less is considered right at the cut point for sarcopenia. And that's a major, sarcopenia is a major determinant of frailty. And frail individuals, as you know, are at a greater risk of falls, fractures, institutionalization, physical dependence, and premature death. Okay, so here are some suggested tools that you could use when you're working with an older population. These come from the 10th edition of the ACSM's guidelines, the American College of Sports Medicine's guidelines. And at this point in the webinar, many of these should look familiar. They should look familiar because a number of them, with the exception of the continuous scale physical performance test, were given to Monica. And you can see that, you know, with usual gait speed, she is below one of the cut points. You can also see that on the right-hand side, there's a newer table now for combined grip strength for assessing grip strength and then putting that into relevance for overall health and for determining robustness, whether someone has a robust profile or whether they're more of a more frail constitution. Okay. So here are some clinical impressions. Let's get our clinical impressions on Monica. There are a couple things that I think stand out, and then I color-coded the slides for things that should jump out and warrant more attention. And then in green, these are some good strategies, some things to think about, things that we would want to emphasize and we would want to use to dictate our direction in our design of programs. So she's a 70-year-old female who reports significant fatigue with routine activities like dog walking, stair climbing, and rapid walking. She has some low back pain, which seems to be triggered by flexion and alleviated by extension. This is a very important piece of information for you going further with the exercise prescription. She has demonstrated difficulties performing some of her activities of daily living because of insufficient muscle strength and muscle power. These observations have been validated by the following assessments: gait speed, grip strength, 30-second chair stand, arm curl, 8-foot up and go, the 2-minute step test, and the 6-minute walk. Monica appears to be flexion intolerant, and trunk and thoracic spine flexion are not advised based upon her reduced bone mineral density, her symptomatology, especially after she walks her dog, and her elevated fall risk. Monica is not currently regularly physically active, participating in 30 minutes of moderate intensity activity for at least 3 times a week for at least 3 months. And that's the American College of Sports Medicine's definition of meeting the regularly physically active requirements to be put in that category. Remember, she was just walking about 10 minutes. And doubles tennis, which is considered approximately a 6-minute activity, when you look in the compendium of physical activities, which is going to be an important tool for us to use with her and with many other patients and clients that fit that profile, that 6-minute activity represents about 100% of her predicted aerobic capacity of 6 minutes based on her walking time on the modified Naughton test. She currently lacks the physical reserve necessary to participate in vigorous activities. She needs to increase her lower and her upper body strength and power, cardiorespiratory endurance and fitness, and her dynamic agility and balance. She needs to increase her bone mass and bone mineral density. Strength training and power training more so, and balance and fall prevention training for dog walking and ambulation on the bus would be warranted. Strength training routines should focus on maximizing osteogenesis through the choice of multiplanar, multi-joint strength exercises with progressive increases in loading and intensity over a protracted period of time. So starting slowly and conservatively. As you see on the left, her 10-year atherosclerotic disease risk is fairly high. That's 12.3%. And it puts her at a higher risk for not just cardiovascular disease, but all metabolic disorders and renal disease and premature mortality. So we want to help her to improve her profile overall. Okay, so implementation and progression. So when we look at a program for her, here are some things that we could do. Now, there are no canned programs, but these are just some things that could be appropriate for Monica. And so you can see I've broken this into endurance training and her strength or resistance training. So what I've done is I'm going to break this and walk this through for you from an initial, an improvement, and a maintenance stage. So let's start with the initial stages. Program could begin during the initial phases of approximately 8 to 12 weeks at a light to moderate intensity of approximately 30% and maybe up to 59% of her VO2 reserve or her heart rate reserve, and with a corresponding RPE of approximately somewhere between 9 and 11 out of 20. Notice I didn't give you an arbitrary number of METs because her total MET capacity is so low that, you know, four METs or even 5 METs, which for a younger person would be considered moderate, would be considered vigorous for her because of her overall lower capacity. So I think in this case, it would be good practice for us to use relativity. So we'll use relative percentages of her VO2 and her reserve here when we're doing this. So an initial goal of accumulating 30 minutes in 10-minute bouts of training between 3 and 5 times a week, I think is warranted. Resistance training should include a single set protocol for all major muscle groups initially, and should be done, you know, minimally twice a week with an intensity load equivalent to approximately 40 to 50% of her 1RM. If you conduct a 1RM, and it may not be warranted in her case with her profile, and I'll discuss that in a moment. And you can certainly start her with lower percentages of what you think her 1RM would be, or of a multiple RM. In this case, the multiple RM testing would be prudent based on her bone mineral density and symptomatology. And the use of an Omni resistance scale, RPE, that's a 0 to 10 scale. That's been validated for resistance training. You could use that to anchor her efforts. And so during her training, you know, an effort of somewhere between 5 and 6 would be appropriate during her sets for starting purposes. When you do RMs testing, typically the highest load at the prescribed number of repetitions that someone can do, in Monica's case, with Monica, where they report above an 8, like an 8 or a 9, and you know, maybe they may hit a 10, but with really good form and control, then you could say that Monica or another client gave it at or near a maximal effort. Her sets could be comprising 10 to 15 repetitions. Those would be appropriate for her age and her novice resistance training status and her deconditioned status. She may not be able to complete all of the repetitions continuously, and she may need a slight break to complete the total number. And again, her tolerance is what will out-trump the numbers. The majority of exercises should be multiple joint, large muscle group activities. Some single joint activities can serve as supplemental. An initial weekly exercise volume of approximately 500 MET minutes a week is appropriate, and it's an appropriate starting goal. For folks with metabolic syndrome, the ACSM, in their guidelines, use a 450 to 750 MET minute recommendation. They also recommend that over the course of time, if tolerated, that the total MET minutes be increased upwards to 1,000, and if someone's trying to lose weight, more than 1,000 MET minutes may be necessary. So you're seeing some representations of activities that would address both her aerobic needs and her low back pain and directional preferences, and her postural needs. These exercises are going to address her osteopenia, her need to improve her strength and her power and her balance and her overall control. And these will set the platform for the next level of training, which we'll see on the next slide. So in the improvement stages, During this period of time, you're going to notice a stepwise increase in a couple of the acute variables in the program. So the intensity of both the endurance and strength training exercise should be progressed gradually following the ACSM guidelines as tolerated. During the improvement stages, the duration of endurance training bouts, they can be increased to more than 10 minutes at a time, and the accumulated time per workout a day can begin to approach 40, 45 minutes, perhaps eventually 60 minutes if it's tolerated, if she has the time and the interest in doing that. Her program most definitely needs to be individualized. Many individuals in Monica's age group are not interested in a protracted program. So although these are guidelines, these definitely need to fit what Monica will do, or else she won't do anything at all, and then her success will be at most limited. So at this point, if it's tolerated, the intensity of her aerobic training can go up to 60% or maybe even a little more of her VO2 reserve or her heart rate reserve. The heart rate reserve would be useful because she is on beta blockade. The corresponding RPA could be somewhere between 12 and 13. When we look at resistance training workouts, they can progress if time permits to multi-set protocols consisting of 2 to 4 exercises per major muscle group, and this is coming from the ACSM's guidelines and from the progression models position paper from 2009. That also states that. This gives her the opportunity to mix the exercises up a little bit per each major muscle group, again, if she has the time to do so. And the loading intensity can go up. It can exceed 60% of the 1RM or the predicted 1RM if you've done some multiple RM assessments there. And the reps naturally would come down a little bit lower to somewhere perhaps between 8 and 12. That would also correspond to her ability to build both some strength and some endurance as well, and to start to increase the osteogenic loading from the lifts and the exercises. And as far as progression goes, in the ACSM's position stand, there's something called the 2 for 2 rule, and how that goes is that if a client can complete on their last set of an exercise more than 2 of the desired number of repetitions with good form and control, and they're able to do that during 2 consecutive workouts, they should be, in theory, ready to increase the loading intensity slightly during the 3rd workout, the next workout after that. But again, movement quality and control, lack of symptoms, and lack of fatigue need to be the major determinant when they're going to decide to do this. But that can be a very useful tool. And also, another thing to think about here is, do you want to increase the frequency of the workouts from 2 to 3, or are you comfortable staying? There is no right answer for this, but as long as Monica can do 2 workouts a week, that's fine. And the fact that initially, as you begin to increase both the intensities and the complexity of the exercises, you may want to keep it at 2 workouts per session. And so there isn't necessarily a correct answer for that. She can perform her strength workouts in a circuit style to save time if she prefers. So that we call that vertical loading. So if you give her a flow sheet that has 8 exercises or 10 exercises, she would do 1 exercise and then proceed to the next exercise until all the exercises from top to bottom are completed. Horizontal loading means that if you're doing multiple sets, Monica in this case would, if leg press or if a wall squat was the first exercise and you wanted her to do 2 or 3 sets, she would do all 2 or 3 sets of her wall slides or wall squats before she goes on to anything else. And it seems that that takes more time out of workout slots when you do horizontal loading. So the vertical may work better for her time schedule, and if you intersperse the exercises, she will not experience fatigue in any one muscle group from a preceding exercise. So she'll be able to go through the workout without suffering by being tired in one muscle group because of the order in which you did them. So that can work out really well if you do that. Other things that are kind of important are to consult the Compendium of Physical Activities, which is an itemized list of work or occupational activities, recreational activities, vocational activities, and such. And these are, they are portrayed by their intensities, their durations, their MET levels, and corresponding kilocalorie expenditure levels. This will make Monica's choices of exercises, if she doesn't want to be in the gym, much broader, and she'll be able to find things that fall within her VO2 reserve ranges very easily. And she'll also be able to find some strength building activities, and she'll be able to have some fun with this. It would be good to spread her aerobic training out on as many days a week as possible, both for kilocalorie expenditure purposes and for mitigating some of these cardiometabolic risks that she has here as well. Okay, let's move on and look at some potential strength exercises that she could use during the initial and improvement phases. These are very safe, as you can see here, and are aimed at targeting her major muscles to help her to improve her posture and her stability. You see the wall slide down below. In this previous slide, I'm going to back up for a second. On the bottom left, you see what's called the Brugger's relief position exercises. So at the bottom of the screen there in black, you see me doing what looks like external rotation, and then it turns into a diagonal horizontal abduction and extension with scapular retraction. That's a really potent exercise for strengthening the posterior chain of the upper body, and it requires minimal equipment. You just need tubing or cables lashed around a pole. And the band is maintained, it's tight and it's crisscrossed, and you're in external rotation and you're just retracting the scapula. And that's a fantastic exercise. It can be done sitting. It can be done in a supine position as well if the person is more comfortable with their head on a pillow. And then you can see some body weight exercises here being important in that stage. But let's go back now to this slide. And what you'll see here is that these are safe. There's truncal support here. There is an emphasis on keeping the trunk in an upright position. And the exercises primarily are fostering a position where she's not doing much flexion. Monica won't do a lot of flexion. Okay, so some precautions. Let's look at a couple of precautions here for Monica. A couple things to be aware of. So again, in red, these are things to be aware of, things not to do. In the green, these are things that we want to do. So she is possible or potentially in a position where she may experience some dizziness due to rapid body position changes secondary to postural hypotension. And she may have reduced somatosensory function, and a number of her medications may cause her to have some hypotensive responses and also some reflexive tachycardia during the exercises. In addition to the general heart rate and blood pressure lowering effects of beta blocker medications, other autonomic functions such as blood glucose release and sweating or pseudomotor control may also be depressed by the beta blockade. So in combination with an increased rate of muscle contraction mediated glucose uptake from both the resistance training and the cardiorespiratory training, Carolyn will be at an increased risk of hypoglycemia. And she may not necessarily know it when it's occurring, especially if it occurs at night close to bedtime or when she's sleeping. Hyperthermia, overheating, and potentially nocturnal hypoglycemia are possibilities for her if she exercises too close to bedtime. So it would be warranted that she does some serial glucose monitoring before, during, and after her exercises before you start changing the routine to later at night. And it may never be advised, possibly, to do it at nighttime. I recently pulled an article on nocturnal hypoglycemia, and I wanted to know what the big deal was. And the take-home message I got from that is that there is a subset of people, and this doesn't happen to everyone, who may be diabetic and who may experience some nocturnal hypoglycemia, who have arrhythmias secondary to that, some of which can be fairly lethal arrhythmias. So there is that possibility in some people, and I just wanted to throw that out as a tidbit of information as to why in some cases it may not be a great idea to exercise too close to bedtime. There are other reasons, as we've discussed as well. A couple other things that come to mind. When you use the stroke risk card, Monica has a number of risk factors for stroke, and she should be educated about these risks and about the early signs and the recognition of things like transient ischemic attacks, TIA, mini strokes, and things she can do to reduce her risks, but things that she should do if she ever experiences some of the warning signs. So you might want to teach her the FAST acronym that we want to teach all of our patients. And FAST basically stands for face. You want her to smile and see if there's facial drooping. A stands for arms. So she would abduct her arms at the shoulder joint to 90 degrees with her palms up, and then bring them out in front of her body so that they're in a 90-degree angle of shoulder flexion. And what you're looking for is to see if one arm drops, and if they drift into pronation on that side. That's called pronator drift, and that's a sign of hemiplegia. That's a sign of weakness on that side. S stands for speech. So you're going to ask her to say something. You're going to say something and ask her to repeat that and see if it comes out garbled or slurred, or if her speech sounds normal, but they aren't the words that you gave her to speak. So you want to look at that, and then you want to look at your watch for the time and get to the phone, because the stroke centers are advising still that within a 1 to 2 hour, especially if it's an ischemic stroke, in some cases now with some of the new research, there are a few cases where up to 4 hours there's a window where the clot busting drugs can minimize, and in some cases prevent any disability at all. So time is of the essence. And there are some new technologies now for hemorrhagic strokes too, for reducing the negative effects of a hemorrhagic. Because in a field setting, you're not going to be able to tell which one is which. You need to teach her that if she experiences any of these symptoms, or she has headaches or dizziness or sudden weakness or blurred vision or any of the others, that she should really get help immediately. So this is something we really need to spend a lot more time with our patients on, because it is is the third leading cause of death, and is the second most frequent cause of death in cardiovascular diseases. So it's prevalent, and probably want to make sure that we make it a point with her. Other things that are important: close supervision and spotting are necessary during exercises and during balance activities, and rapid postural changes should be avoided in order to prevent dizziness and postural hypotension. If she falls, she might sustain a fracture. So when you're doing the strength training routine, try to set it up so you're not asking her to get up and down and up and down. And the same thing if you're going to use multiple modes of cardiorespiratory training. So if she's going to be in a recumbent position and you want her to also be standing, kind of plan out, how you change the positions a little bit, and teach her that as well. Again, upright postures during exercise with spine support, minimized flexion and rotation are going to be good for her because of her reduced bone mass as well, bone mineral density. And again, just preventing sudden changes in body positioning. As I mentioned before, glucose monitoring before, during, and after exercise is prudent. And Monica should bring a carbohydrate snack with her in the event that she experiences some dizziness or hypoglycemia. And she should definitely, even though she's on medications for blood pressure, she should definitely be well hydrated. In addition, other important things to consider are the use of the Borg scale and the Omni RPE scale, especially the Omni for her resistance training. To think about using multiple RM tests instead of one RM strength tests. And you might not even need to do any testing. You can just look at her movement quality, find an activity that is challenging, a lift that's challenging, or an exercise that's challenging for her to finish with the prescribed number of repetitions where she still has some control. The last repetition is definitely the last repetition, and she's reporting a very high RPE on the Omni scale, at least 8 or more. And that may be the way to go over the course of time, at least initially, and look to see if the reps go up, the repetitions go up, and correspondingly the Omni RPE ratings go down. So it's not always essential to be testing constantly either a one or a multiple RM. So I'm just offering you some different options to see what would work best for you in your situation with your patients and your clients. Start with light to moderate intensity activities and progress using the ACSM guidelines as tolerated. Now, because she's on a statin medication, there are some subsets, and this is not every patient, but there are some people who do have a sensitivity to them, and they may experience myositis and myalgias. And in some cases, some people may have some color changes in their urine. So these are just some things to ask her to look for, and to just to double check with her to see if she's experiencing any of those things. And again, that's all the more reason to encourage her to be very well hydrated, because in some people there is the potential for a dangerous, threatening disorder called rhabdomyolysis, but that's not in everyone, but it is a possibility. So you want to just have that discussion. Okay, this is a sample resistance training program spread out over a 20-week period. And what you see here is that I've put in, the abbreviations are on the bottom, the legend for that is down below. I'm encouraging different types of activities, so many different modes of strength building activities. So they're body weight activities, dumbbells, kettlebells, resistance bands, elastic bands. They're all appropriate if she can tolerate them, if she can do them pain-free, and if she can do them in the upright truncal position, if she can do them without being dizzy, without falling. And what you're looking at is every couple of weeks during the initial phases of the workout, you're seeing some slight increases in the loading intensity, or predicted 1 rep loading intensities. And for the first few weeks, we're keeping a single set profile with a 60-second recovery period between sets. And then as we start to approach, as we get closer to what would be the improvement stages, you start to notice some changes. There's some changes in the types of exercise modes that you're using, because initially we want Monica to develop movement proficiency and competency. She should be able to squat properly, to hinge at her hip properly, to perform a hip hinge and not have to bend at her waist. She should be able to tilt her scapula back when she's raising her arms over her head, and to effectively retract her scapula. She should have good shoulder external rotation. She should be able to do all of these things and bring her arms over her head without sticking her head forward. So good movement quality and control is always going to be more important than the complexity of the exercises, the number of the exercises, or the amount of weight or resistance. So it's sort of motor learning 101 during the initial phases and the beginning of the improvement phases, and should be done very basic, very simple and easy. And then the complexity and the degree of difficulty can come with time, again, if tolerated. And that's what you see here in the latter weeks of this program, which would be getting her ready for what we would call the maintenance stages of the exercises. Again, it would be very good, it would be prudent to have her blood pressure monitored before, during, and after the exercise program, especially if she's going to be using upper body exercises and large multiple group exercises as well. Another little tidbit is that if you're concerned about blood pressures and on rate pressure product, for her, when she's doing upper body exercise in the dumbbells, you may want her to alternate to do one arm then the other, because it does cut down to a degree the hemodynamic demands on the patient or on the client. So those are some things that you can do as well. So let's move on. Here are some samples of activities represented by their MET levels, and they're broken into very light or light, moderate, and vigorous. These are extrapolated from the Compendium of Physical Activities from Dr. Barbara Ainsworth and her colleagues. And on the right side of your screen, you see some links to that tool and to some of the searching tools within there. And this is a fantastic tool that you can use with a patient like Monica. You can even familiarize her with this and let her start picking and choosing. One point that I think is important to mention here is, as you note, they're categorizing very light and light as being under 3 METs, moderate at 3 to 5.9, and vigorous at or greater than 6 METs. Let's recall now that Monica's predicted VO2 max based on her performance and fatigue level during the modified Naughton test is 6 METs. So for her, for us to say that a 4 or a 5.9 level activity is moderate. I think you can see now and appreciate that those would probably be vigorous for her. So why I'm bringing this up is we need to be realistic with her and help her set goals that are not too aggressive early on, so that we don't hurt her, we don't cause her to have a fall, we don't cause any other untoward event, and we give her things that she can look forward to doing as she raises her physical capacity. So again, at this stage, we should probably use relative VO2 measures, heart rate reserves, percentages of heart rate reserves, percentages of VO2 reserve instead. Okay, so at this point, I have some electronic resources here for you that I think belong in every clinician's toolbox. And medlineplus.gov is funded through the National Institutes of Health, the National Library of Medicine. And this is a wonderful tool for learning about pathology, medical management, diagnostics, but they also have a fantastic link in there on drugs and supplements. And this particular website will also bring you right into a PubMed search as well, and lots of great patient education information from the leading health organizations in our country and in the world. Drugs.com is a very quick and easy indicator. The 10-year cardiovascular disease risk calculator, many of you are probably using that now. Exercise prescription on the net, we call it exrx.net, is a fantastic tool for exercise instruction and technique, testing, gathering norms and things like that. And enough cannot be said about the compendium of physical activities. And as you go down the list here, the National Stroke Association, which is also affiliated with the National Institutes of Health, the American Heart Association and the American Stroke Association work together. I don't have their direct link other than here, My Life Check Life's Simple 7 screening tool from the American Heart Association. Once you're in there, you can go to the For Professionals link and it can be brought right into the general information for the American Heart Association and the American Stroke Association as well. Go for Life from the National Institutes of Aging is wonderful, because this is a place where you can work with someone like Monica and help her to learn, and she can, there are lots of modules she can learn, but there's a lot of visual tools there. That's where a lot of the animations that you saw on the slides came from, and that's helpful to her. Carolina Geriatric Education Center, that's at the University of North Carolina, Chapel Hill. I'm sorry about the spelling mistake down below there. They have a wonderful website that has videos of a number of assessments that you could use with patients like Monica for gait speed, for balance, for fall risk, and then a number of basically canned exercises that you could use to help to improve upon the condition. So they use what's called the Otago fall risk assessment, and you could see really nice examples of that in that website. These are some references that these should show up when you obtain your PDF of this. And I think you'll see these are just two additional assessments that are very useful. This is called the functional reach assessment, and it's kind of important when we use this is to not just measure whether the person can get 10 inches or more, but to look at the strategies that they use when they're bending and then when they right themselves. And this is an assessment on the right from Dr. Joseph Signorilli. It's called the Gallon Jug Shelf Transfer Test, and it basically enables you to measure total body power. You fill 5 jugs with water. The jugs start at patellar height. The top shelf is at acromion height. You start your stopwatch as soon as the person grabs and starts to move the first jug. And you time them. You stop the watch when the last jug hits the top of the shelf. And there are norms for that as well, for that test. So that's a full body power test. And they can use 2 hands if they want to as well. So at this point, I'm going to stop. I want to thank the ACSM and the Clinical Exercise Physiology Association for inviting me to do this. And I want to thank you, more importantly, for attending today, and I'm going to stop and see if there are any questions. Thank you so much.
All right. All right, Pete, we do have one question, and as Pete reads this question, if you have a question, I welcome you to type your question in a little question tab for Pete to answer right now. Are you able to see the question from Elaine, Pete?
I am going to hit the question tool now. I see part. I can only see part of it. Let me see. It says, yeah, it's kind of small and obscure. Is it possible that you could read it to me?
Okay. Which two tests did you say were the most important if you're low on time? You said the grip test and something else.
Oh, thank you for asking that question, Elaine, and I'm sorry. Yes, so if you wanted to determine if your client is frail and if they're going to be at risk of falling and such, and I would say a self-selected gait speed or walking velocity test and the grip strength test. Those are the two that the European Working Group for the definition of sarcopenic obesity, they recommend those two. And those went with the algorithm that we were looking at. So those two things, I would say, for functional fitness, those would be two things if you were limited for time.
And we're just waiting to see if anyone else has a question. I would like to remind everyone that I will have a copy of the slides emailed to you along with a link to this video recording. Give me about 24 hours, you will have that link sent to your email. All right. Pete, I'm not seeing any more questions right now, so there are no more questions. I think it's a good time to conclude the webinar. Again, I'd like to thank Pete for his time and putting together this excellent webinar, and thank everyone else for showing up. If you have questions, feel free to email us, and either email me or Pete, and I will pass those questions along to Pete. All right, thank you, everyone.